deep breath in through your nose. Smell the fresh air and the colon prep. And now out through your mouth. Now that we're all relaxed, let's go over our clinical case. Lawrence Lynch, a young, friendly mushroom farmer from Amsterdam, is presenting to the clinic after he underwent a diagnostic colonoscopy. After reviewing his chart, we see that initially, he presented with rectal bleeding, abdominal pain, and unintentional weight loss. Exam in the office was generally negative. On labs, he had iron deficiency anemia. But the interesting part comes in when we look at his family history. His father and his brother both have colorectal cancer. Holy cow! Or should I say, holy colon. Yeah, that works. And not only that, but his sister, Lula Lynch, has endometrial carcinoma. Holy cancer! This poor family. Must be something in the water. Or could it be in their genes? No, I don't mean their denims. I mean their genetic genes. Well, biopsy demonstrated invasive adenocarcinoma. Well, shoot, that just tanks, doesn't it, guys? Poor Lawrence. Well, the question is asking, if present, what underlying genetic condition could be the underlying cause? Well, I was spot on with the denims. The genes. And, well, something is on the tip of my tongue. No, a bunch of letters. NHPPC, CCPHR, PAFCC. I'm getting these all confuzzled. Let's move along through this sketch and see if we can see what I'm trying to remember. Dreamy little polypet family farms, where magical redcap mushrooms and carrots grow aplenty. Wait, what? Looks like there may be an invasion underway, which is the perfect background to talk about invasive colorectal cancer, specifically the factors leading to the development of colorectal cancer, as there's a complex interplay of genetics and environmental risk factors. So many, in fact, that the other parts of colorectal cancer screening and management are in their very own sketches. Colorectal cancers are nearly universally adenocarcinomas, which is why our cancer crab-esque beetle is wading through a puddle of the bubbly, a recurring symbol for the glandular-derived adenocarcinomas. The current thinking is that they arise from adenomatous polyps, which, over time, progress to invasive adenocarcinoma through a process called, aptly, the adenoma to carcinoma sequence. Behind the adenoma to carcinoma sequence is a combination of genetic and environmental factors. The overwhelming majority, as in greater than 95% of colorectal cancers, develop sporadically and share a few well-documented risk factors. It also looks like a few of the risk factors for colorectal cancer, including the bubbly, are conveniently grouped together here. This family photo is here to remind you that family history is an important risk factor for the development of colorectal cancer, as colorectal cancer in a first-degree relative pretty much doubles the risk in related patients. Also, we're talking sporadic cancer here, not cancers associated with familial syndromes. So, while family history of colorectal cancer is a risk factor, don't confuse family history with familial syndromes. It's important. Write that down. For our clinical case, he's definitely got a strong family history, but it seems like there's something else going on. We'll come back to him, but for now, let's continue talking about sporadic cases. A few known environmental and lifestyle risk factors also contribute, including smoking, heavy alcohol use, high-fat diets and obesity, and, interestingly, type 2 diabetes, as it is with pretty much everything else. Inflammatory bowel disease, especially ulcerative colitis, is also associated with an increased risk for colorectal cancer. Not only that, but the risk increases with greater duration, degree, and extent of disease. This is due to cycles of inflammation with the body trying to heal the tissue in between. Healing tissue requires lots of cellular regeneration. And where there's cellular regeneration, there are errors in DNA duplication, giving avenues for the development of cancers. Transformation of normal mucosal cells into malignant ones via the adenoma to carcinoma sequence occurs over the course of about 10 years and involves progressive mutations as the polyp grows. To remember the 10-year interval over which invasive colorectal cancer develops, remember this invasive beetle knocking out a Roman numeral 10 shaped section of the fence. First off, initial adenoma formation. Typically, a mutation that inactivates the APC, which we can remember here as a pulled carrot. Tumor suppressor gene causes beta catenin and E cadherin to run amok, leading to problems in intercellular attachment and an epithelial cell cluster that starts growing outward into the lumen, aka polyp. Once an adenoma develops, it starts to grow. This often involves a mutation of the KRAS proto-oncogene, which leads to constitutively activated GTP bound protein and unstoppable cell division. Ooh, I hate rats, especially one that big, with polyps growing on it. Whew. Anyhow, this leads to uncontrolled growth of the adenoma. And if you remember from the colorectal screening sketch, size of the adenoma is directly correlated with cancer risk. And finally, invasion of the basement membrane and muscularis mucosa, which transforms an adenoma into adenocarcinoma. This step may involve the collective effect of multiple gene mutations, with two being most important: P53 and DCC. The P53 tumor suppressor gene, symbolized here with the broken checkpoint gate, is responsible for preventing the G1 to S phase transition if anything is off, activating DNA repair, and even initiating apoptosis. And then there's DCC, which literally stands for deleted in colon cancer. DCC's primary function in cells is to activate the apoptosis pathway when things are abnormal. So, take apoptosis away from mutated cells, and they live indefinitely, getting weirder and more mutated. A lot like Charlie Sheen over the last 10 years. Before we move on to the familial syndromes, there are two important things you should keep in mind. First, family history is not the same as familial syndromes. Most colorectal cancers, even in patients with a family history, are sporadic. You're likely to see hundreds of people with colorectal cancer and a positive family history. You're also likely to rarely see a patient with colorectal cancer due to a familial syndrome. Why? Well, even though they're tested on 100% of the time, familial syndromes are the cause of colorectal cancer less than 5% of the time. We should also remember that patients that do not present with a typical presentation for colorectal cancer should make you wonder if they have a familial genetic condition resulting in colorectal cancer. If concerned about cancer, they should get a diagnostic colonoscopy. This includes patients presenting at a young age, say, for example, 28, or patients with a very strong family history of colorectal cancer, like a dad and a brother, or other cancers at young ages in their family members. Such as a sister with endometrial cancer? Or even patients that have known invasive cancer at a young age. Patients in all of these situations should be screened for genetic conditions by a genetic counselor. If you didn't pick up on the hints I was dropping, all of those sound just like our clinical case, Lawrence Lynch, from the beginning of the sketch. Ah, the lynchworm inchworm. Storming the farm. Love that guy. And it seems like the queen of the evil polypets is riding on top. The most common familial colorectal cancer syndrome is hereditary non-polyposis colorectal cancer, also called Lynch syndrome, which is caused by an autosomal dominant mutation in DNA mismatch repair genes. Hence the mismatched shoes of the evil queen. A unique feature of Lynch syndrome cancers is that though they do develop from adenomas, they tend to be flat and highly dysplastic already, i.e., not from a polyp sticking out into the lumen. Hence why this is called non polyposis. No polyps. This makes them more difficult to detect early, especially if the patient is at seemingly low risk for colorectal cancer. Hey, now I remember that combination of letters. HNPCC, also known as Lynch syndrome. Well, that was a giveaway with Lawrence's last name. Wonder why I didn't catch that. Must be slipping. To remember that this change is autosomal dominant, look at the little bridge the lynchworm just crossed, and you'll notice it's now a large domino. Patients with Lynch syndrome also have an increased risk of ovarian, endometrial, bladder, and even gastric cancers. And again, even though Lynch syndrome is the most common familial colorectal cancer, it makes up less than 3% of all colorectal cancers. Lynch syndrome should be suspected when patients meet the Amsterdam criteria, which we'll remember here using the 3-2-1 rule. 3 first degree relatives with Lynch associated cancers over 2 generations with one colorectal cancer diagnosis under 50. That certainly fits Lawrence from our clinical case. He's got 3 first degree relatives: his dad, his brother, and his sister. And it definitely involves 2 generations. And not just one, but all of their cancers were diagnosed before age 50. How can we be sure, though, that Lynch syndrome is what's going on? Remember, we just talked about how rare it is? To confirm the diagnosis, patients undergo genetic testing for the germline DNA mismatch repair gene mutations. In addition to confirming the diagnosis in a patient with suspected Lynch syndrome, genetic testing should be performed on first degree relatives to help with early diagnosis. So, if Lawrence from our clinical case has any other siblings, they should all be tested to see if they carry the gene to aid in the early diagnosis of any cancers they may develop. Notice this proboscis right here next to the 20 hidden in the shoelaces and birthday candle. This is here to help you remember that patients with Lynch syndrome should start having screening colonoscopy every 1 to 2 years, starting at age 20 to 25, or 5 years before the youngest colorectal cancer case in relatives, whichever comes first. So, in the case from the start of the sketch, Lawrence should have had his colonoscopy between 20 and 25. As going by the age rule, he wouldn't have had screening until 34. 20 comes before 34. So, in this case, he should have already had screening. Of course, at the time, we didn't know he had Lynch syndrome. This would just be in the case where Lynch syndrome has already been diagnosed. If high grade dysplasia and cancer are found on screening colonoscopy, patients undergo total proctocolectomy, not segmental resection or hemicolectomy, due to the high risk of recurrence. This means we take every part of the colon and rectum, not just the portion with cancer in it. Due to the increased risk of developing gastric cancer, patients with Lynch syndrome should undergo screening EGD with biopsy for H. pylori at age 30. So in comes another proboscis, this time in a mouthy flower above the XXX, i.e., 30, shoelaces. If there are red flag findings on the initial screening EGD, such as gastric atrophy, polyps, or early metaplasia, or if there's a family history of stomach cancer, surveillance EGD should be repeated every 2 to 3 years. Women with Lynch syndrome are also at a highly increased risk for developing endometrial and ovarian cancers. Starting at age 30 to 35, women should undergo annual endometrial biopsy, symbolized by the grabber, and transvaginal ultrasound, symbolized by the bullhorn, to screen for endometrial and ovarian cancers. Sadly, in our clinical case, Lynch syndrome was not diagnosed yet. And so Lawrence's sister Lula was not screened and ended up getting endometrial carcinoma. And because you can live without a uterus and ovaries, women with Lynch syndrome are offered prophylactic hysterectomy with bilateral salpingo oophorectomy around age 40 or when they're done procreating. The goal is to decrease the risk of endometrial and ovarian cancer as soon as possible without taking away their choice to bear children. And as an added bonus, when counseling female patients with Lynch syndrome, you get to say what may very well be the most magical medical term there is: total abdominal hysterectomy with bilateral salpingo oophorectomy, if you can. I could not the first 5 times. All right, well, that pretty much sums up Lynch syndrome, or HNPCC. Lawrence has his diagnosis, and we have our clinical case answer. Now to get Lawrence all prepped for surgery. A couple liters of polyethylene glycol should do the trick. Meanwhile, while he's drinking that, let's finish up with the other familial syndromes. This family of polypets running through this polyp garden are here to remind you of another familial colon cancer syndrome, familial adenomatous polyposis, FAP, which presents with the development of thousands of polyps carpeting the colon in very young patients. FAP is caused by an inherited autosomal dominant mutation in the APC tumor suppressor gene on chromosome 5. And yes, that's the same APC as in sporadic cases. These patients just come out of the gate lacking one copy already, which greatly increases cancer development, which occurs in 100% of patients. Hence the 100% guarantee on this familial farm. This is why prophylactic total colectomy is performed, or at least offered by age 20. Whoa, that's a big bird. Let this bird munching on this colon worm remind you that in familial adenomatous polyposis syndrome, prophylactic total colectomy is recommended by age 20. We said it twice because you don't want to forget to offer this to your patients. FAP doesn't stop with colorectal cancer, however, and has two interesting spin offs. Turcot syndrome is a form of FAP associated with brain tumors, especially medulloblastomas. So, for this, it's recommended to perform a prophylactic cerebrum resection, which decreases the risk. Hey, wait a minute. Who wrote this? That's not right. Despite the name Sketchy Medical, here at Sketchy Medical, we do not condone prophylactic brain resection. Anyway, Gardner syndrome is a form of FAP associated with osteomas and other soft tissue tumors, especially intra-abdominal desmoid tumors. So we've brought in this brainy turban for Turcot syndrome and a bony cactus Gardner for Gardner syndrome. As with Lynch syndrome, for patients with FAP, colon cancer screening guidelines differ from the general population guidelines. Screening colonoscopy should be performed yearly starting at age dozen. Yeah, I mean 12. So we've sketched in this proboscis and birthday candle right next to the dozen carton. Haha, happy birthday, little Timmy. This year you get a colonoscopy. Yay! Poor kiddo. Also, because of the risk of duodenal polyps and subsequent malignant transformation, EGD should be performed every 1 to 2 years when colon polyps develop, or by age 25 to 30, whichever comes first. Juvenile polyposis syndrome is an autosomal dominant syndrome that causes the development of hamartomatous polyps in children. To help you remember hamartomatous polyps in juveniles, here's a tiny baby polyp head swinging from a big hammer. In fact, patients with juvenile polyposis can have hundreds of polyps, typically in the rectum, before their 5th birthday. Have you spotted a theme that may make things easier to remember, say, for example, on tests? All of these conditions are autosomal dominant. While the polyps themselves are non neoplastic and therefore not premalignant, juvenile polyposis syndrome is still associated with an increased risk for colorectal cancer, which is why there's just the shadow of a cancer beetle looming here. Sorry, kid. Juvenile polyposis also has its own screening guidelines. These include a yearly colonoscopy starting at age 12, or sooner if symptomatic, and a screening EGD. If duodenal polyps are found, EGD should be performed annually as well. Well, geez, all these family syndromes are pretty terrible. Little kids with thousands of polyps? Luckily, we should remember that all of these make up only 5% of all colorectal cancers. So very, very rare. Cool, let's sum things up. Colorectal cancers are nearly universally adenocarcinomas, thought to arise from adenomatous polyps, which over time progress to adenocarcinoma through a relatively well defined sequence known as the adenoma to carcinoma sequence. Risk factors for colorectal cancer development are as follows: family history unrelated to familial syndromes, old age, smoking, alcohol, obesity, and type 2 diabetes. IBD, particularly ulcerative colitis, also carries an elevated risk of colorectal cancer, which increases with duration, degree, and extent of disease. These risk factors contribute to the transformation of normal mucosal cells into adenomas and finally into carcinomas. This may take approximately 10 years. The genetic transformation is as follows. The APC tumor suppressor gene is inactivated by a genetic mutation, causing problems with intracellular signaling by beta catenin and E cadherin, leading to increased cellular proliferation and development of a polyp. KRAS is a proto-oncogene that is also often dysregulated, leading to dysregulated cell division and proliferation, causing growth of the adenoma. Finally, loss of P53 and DCC tumor suppressor genes allow the adenoma to grow unchecked and without the ability of cells to perform apoptosis if they sense DNA damage. It grows through the basement membrane, becoming invasive adenocarcinoma at that point and becoming cancer. There are several familial syndromes that are associated with colorectal carcinoma that make up less than 5% of all colorectal cancers. Hereditary non-polyposis colorectal cancer, or HNPCC, also known as Lynch syndrome, is an autosomal dominant mutation in DNA mismatch repair that highly increases the risk of development of colorectal cancer, as well as other cancers including ovarian, endometrial, bladder, and gastric cancers. Amsterdam criteria allow for the identification of patients with likely Lynch syndrome. These criteria are three first degree relatives with HNPCC associated cancers spread over 2 generations, with at least one occurring before age 50. Genetic testing will confirm the diagnosis. Patients with known Lynch syndrome should be screened by colonoscopy annually or every 2 years, starting at age 20 to 25, or 5 years before the youngest case of colorectal cancer in a relative, whichever comes first. If high grade dysplasia or carcinoma are found, a total abdominal proctocolectomy should be performed due to the high risk of recurrence if only partial resections or hemicolectomies are performed. Patients with Lynch syndrome should also undergo EGD with biopsy for H. pylori at age 30 due to increased risk of gastric cancer. If there are concerning findings, such as atrophic gastritis or polyps, surveillance EGD should be repeated every 2 to 3 years. Women with Lynch syndrome should also undergo annual endometrial biopsy and transvaginal ultrasound for surveillance for endometrial and ovarian carcinoma. At age 40, or when the woman is done procreating, she should be offered prophylactic total abdominal hysterectomy and bilateral salpingo oophorectomy to decrease the risk of development of these cancers. The next syndrome is familial adenomatous polyposis syndrome, or FAP. This autosomal dominant syndrome presents with the development of thousands of polyps throughout the entire colon. This is due to mutation in the APC gene being passed genetically down, whereas normally this takes time to develop as mutation in sporadic cases. Patients with this syndrome have a 100% chance of developing colorectal carcinoma. Prophylactic total abdominal colectomy is recommended by age 20 prior to the development of carcinoma. Turcot syndrome is a type of FAP associated with brain tumors, especially medulloblastomas, and Gardner syndrome is a type of FAP associated with osteomas and soft tissue tumors, such as abdominal desmoid tumors. Patients with FAP should undergo screening colonoscopy beginning at age 12 and continuing annually. Patients with FAP should also undergo EGD every 1 to 2 years, starting when polyps first begin to develop or at age 25 to 30, whichever comes first. The last familial condition to summarize is juvenile polyposis syndrome, an autosomal dominant condition that causes the development of hamartomatous polyps in children, often with hundreds developing before age 5. Although the hamartomatous polyps are generally benign, the condition is still associated with an increased risk for colorectal cancer, and so annual screening colonoscopy should begin at age 12, and EGD should be performed at age 12 as well to assess for duodenal polyps, which, if present, indicate the need for annual EGD screening as well. Well, that about does it for colorectal carcinogenesis and the associated familial syndromes. Head on over to the next sketch on colorectal cancer for the final chapter in this polypet saga. Where will we find them next now that they've been run out of their homes by the evil purple polypets? The anticipation is palpable. All right, Lawrence, you about done with that colon prep? Yeah, guess that means you're done. Time to take out that colon.
Exacte, i clar, al no ser-hi, a mi germà,